a picture which I got to show you what we're calling the ring of contraction. Okay, you can see this, okay, it's kind of like segmented. So if you had another constriction down here at the bottom and another one up here, if you have those areas contracting at the same time, and then they relax, and then in the middle here where it's fully dilated or vasodilated, then it is constricted, then you can see how you can get the segmentation. Okay, but I also like this picture because it shows you the blood supply. You can see it through, and also you can see the fat, the yellow. There's a lot of fat here, yeah? And this is the fat which makes you have a protruding abdomen. So what we're saying is that when you go to exercise in the gym, this is the fat that you're trying to get rid of. And this one you can't get from exercising, from touching your toes. What I'm saying, you're not exercising these smooth muscles. So in order for you to get rid of this fat, which is around the abdominal organs, you just have to stop eating and let your body make use of what is already in the stores. Okay, so finally, I think we're almost at the end of motility, and we're looking at motility of the colon. And remember, in the colon is where you get the final absorption of salts and water. So any salts that have escaped absorption when the contents are flowing through the small intestine, they will be absorbed in the colon. And the colon mucosa is specialized in such a way that it absorbs water against its concentration gradient. Okay, so water is being absorbed along the entire length of the gut, but the colon especially is able to turn contents from semi-fluid to semi-solid because water is can be absorbed against the concentration gradient of water. Now why do we need to convert it from semi-fluid to semi-solid? To allow for orderly evacuation of feces. If that didn't happen, we'd have to walk around with diapers, because it would just be coming, it would just be flowing through. In fact, even when your external anal sphincter, your sphincters will not be able to contain the luminal contents. So the colon receives about between half a liter to 1.5 liters of chyme per day. And the contents progress very slowly. So if you look here, you can see that the rate at which the contents progress is about 5 to 10 centimeters per hour, which is much, much slower than what we saw in the small intestine. Now, we talked about the Taenia coli and their arrangement and how it is that they're able to compress, because even though they're propelling the contents from one part of the colon to the next, they are still kneading the contents, mixing it up in order that you get the luminal contents coming into contact with the colonocytes so that they can absorb water, so that the microbes, the colon microbes can finalize the digestion, produce the vitamins and the short chain fatty acids so that they can be absorbed and used again. Mass movement we talked about, so I'm not going to talk about that again. And Hirschsprung's, like I told you guys, is actually Mr. Hirschsprung is the one who first described it. So it's known as Hirschsprung's disease, but its technical name is congenital megacolon. Congenital because it's a developmental defect. And we said the defect is because you get failure of the neurocrest cells to migrate all the way down to the rectum, or to the sigmoid colon and the rectum. And so what happens is that you get failure of development of the enteric nerves and the enteric ganglia. And so what happens when the baby is born, whatever matter or luminal contents are going to come down, they accumulate there, they cause distension, but you do not get the stimulation of the peristaltic reflex because of the lack of ganglia and the lack of enteric nerves. So that part of the colon just gets large, the terminal part of the colon gets larger and larger as the baby accumulates. And typically it's found within it's diagnosed between 3 to 4 days when the baby has not passed the meconium. The reflexes, these ones were discussed earlier. So this gastrocolic reflex, colonic reflex. And we said gastrocolic, it means the stimulus is in the stomach, but the results you will see in the colon, okay? You have an increase in frequency of mass movements and increased motility of the proximal and distal colon in response to the meal entering the stomach. So when you have eaten and your stomach is fully distended, you're full, messages are sent forward, this is a food forward reflex to the colon, causing mass movement and the urge to defecate so that you can evacuate the colon to produce, so you can have space for the gastric contents to find their way there. Colonocolonic reflex is descension of one part of the colon resulting in reflex relaxation of other parts. So we're talking about, remember, you've got your ascending colon, horizontal colon, descending colon, sigmoid colon, and you cannot move all of that mass all at once, the luminal contents at once. So that's just information circulating between the enteric nerves within the colon itself. Now, when it comes to the rectum, defecation, yes, which is now the final. We talked about how we ingest food, what happens to the food as it travels along the entire gut, and now we're at the other end. And defecation requires coordination of rectum and the anal canal, and it's a very complex behavior that involves reflex, a combination of reflex and voluntary actions. The integrating center for defecation lies in the sacrospinal cord. So that's why you find that people who are involved in road traffic accidents or who have damage to the lower part of the spine, they have difficulty voiding. In fact, sometimes the defecation process continues without their voluntary control until they learn to control it later on. But immediately, that is what happens. So that's what I'm saying. The modulation process is by the higher centers, but the pelvic nerves are usually involved. Now, normally, the rectum is empty, okay? So what you're saying, you have content in all the other part of the large bowel, but normally the rectum is empty. And this is because it has more active segmental contractions than the sigmoid colon. So what happens is that when the rectum, when the contents come to the rectum, they tend to move back into the colon. But once the rectum is filled and you get distension of the rectal walls, that is what causes or gives you the urge to defecate. That distension is carried by the nerves, the pelvic nerves, it's directed all the way to the central nervous system, and you're aware now that you need to go to the toilet. But at that point, one, you get reflex relaxation of the internal sphincter, because it's also going to dilate. Remember, the internal anal sphincter is innervated by the enteric nervous system. But you have reflex contraction of the external anal sphincter. So basically what we're saying is that you have control over the external anal sphincter, the relaxation and contraction of it, but you don't have control over relaxation and contraction of the internal anal sphincter, because that smooth muscle, which is innervated by the enteric nerves. So you get relaxation of the internal anal sphincter, but the external one is still contracted. And this is just to show you a picture anatomically to remind you of the anatomy of the anal sphincters. And you can see here that the sphincters are actually at the same place. The internal sphincter is internal, and it is surrounded by the external anal sphincter, which we said is completely made up of smooth muscle. So as the contents come down, they're going to cause distension of the wall, and what you're going to get is the reflex relaxation of the internal anal sphincter. However, you are the one who's going to control the external anal sphincter when the environment is conducive. Okay, so we don't go around just pooping like the way cows and goats do. So we are able to control that. Now, the reflex reactions of sphincters to distension are transient. Okay, this is a good example. This is what happens, for example, let's say you're in a bus and you're traveling to Mombasa. Okay, it's in the middle of the night. Okay, what are you doing awake at the middle of the night? Okay, whatever time it is, okay? And you feel the urge to go for a long call. But the bus is still going and it's not stopping for another 45 minutes. What happens is that urge that you're feeling dies away. It temporarily subsides. And then after a certain length of time, maybe half an hour, you'll be reminded again that you need to go to the loo. So what we're saying is that once you have the distension, it doesn't mean that you have this urge and you feel this urge all the time. So at appropriate circumstances, voluntary relaxation of the external anal sphincter allows defecation to proceed. Okay, and the efferent pathways are cholinergic by the parasympathetic fibers in pelvic nerves. So this is also another process that you have done for many, many years. You don't think about it anymore now, unless you have a problem. And this slide just shows you the 7 steps that are involved in defecation. They've been taken from your textbook, so I've just written, this is just summary, so you'll go and read and be able to understand what exactly happens. So first, what happens is you have the external anal sphincter voluntarily held in the relaxed state. So this is when you have sat on the loo, okay? So the first thing that you do is relax the external anal sphincter. Then you have to build up the pressure in the abdomen in order to aid in the expulsion of feces. And how do you do this? You take a deep breath that moves the diaphragm downwards, because remember the diaphragm is a dome shape. So when you take a deep breath, it's going to flatten and it's going to press and squash the contents of the abdomen. You close the glottis to keep the air in, so the pressure in the thorax is maintained. And the contraction of the respiratory muscles elevates both the intrathoracic and the intra-abdominal pressures. And this is what is known as a Valsalva's maneuver. Then you then tend to contract the abdominal wall, the anterior abdominal wall, and this further increases the intra-abdominal pressure. And since you're in a squatting position, your pelvic floor will then be lowered. And when the pelvic diaphragm is lowered, it pulls the sigmoid colon, so it stops being sigmoid in shape and kind of like straightens it out. And then the feces are then forced out through the relaxed sphincters. So this whole process is what takes place. So if you have constipation, when you sit on the loo, even if you build up the pressure in the thorax, in the abdomen, you cannot control or force the smooth muscle to contract. So first things is always work with your body so that when you have the physiological, when you have the urge to defecate, know that the system is primed and everything is ready. If you're able to relax your anal sphincter at that point where you feel the urge to defecate, then when you sit on the loo, everything just moves out smoothly. But if you haven't, or if you're not in the habit, if you are one of those people who goes to the loo once a week for a long call, when you sit, you feel, yes, the urge, you know, because the feces now is hard. It's now going from semi-solid to almost solid, and you can't generate enough force. You can't contract the musculature in the rectum or even in the colon to push the contents out. So that's where the problems come in. This picture I always leave in, you know, this because much as though we think that this is just something you need to know in theory, practically, this is very useful. And these days, when you're building your house, I'm sure many of you are, what's it called? You're anticipating you would like to have a Western type toilet, the one where you sit on. But then you see now, when you sit like this, your body is not quite too sure whether you're sitting on the toilet or whether you're sitting on a chair. And if you go to old buildings, old hotels, you actually find, okay, another thing I've noticed, by the way, even in malls, I think because they don't want you to sit in the toilet for too long, they have the seats, the toilet seat very, very high. So when you sit, sometimes even your feet are hanging off the ground. That would be very difficult for you to be able to perform the Valsalva's maneuver. But When you use a toilet, which is a hole in the ground, when you squat, you can see now that the pelvic floor, what happens is that you stretch out the sigmoid colon, and you're able now, when the pressures are built up in the intrathoracic and intra-abdominal areas, then once you push, then everything comes out very easily. So what I've noticed over the years is that the toilets themselves, are actually getting lower and lower, because people have learned ergonomics, and they're seeing that it's very important that when you're sitting on the loo, your body gets that information that you're sitting on the toilet, because it's not a low seat, it's actually very, very low. So you're almost in squatting position. Whereas when you sit on a loo, which is as high as your, what's it called? Your bench seats your stools in the lab, you sit on that and your body gets kind of confused and it doesn't know what to do. So even things like that are coming in. So the way they're improving the chairs that you sit on in the office, the chairs that you sit on in the car, even when you're driving, they're now ergonomic, bent to hold your back and your spinal cord. Even the toilets are being, they're using the physiology is being applied to make it easier for you to be able to go to the loo without causing problems. So sometimes if you have constipation and you go to a doctor, they may advise you when you go to the loo to have a stool, so that even if you're using the sit down, the toilet, you sit, but then you raise your feet up. You have the stool, and that will almost emulate a squatting position, and that will facilitate in moving of the fecal matter. So a quick run through of clinical applications. Constipation, we said, comes about because of, one, not listening to your body and not going to the loo when you feel the urge to go. And there are many things, as we said. It could be inconvenient, you could be traveling, you could be in a plane, you could be anywhere, or you may be in a situation where in the environment you go there and the toilets are so dirty, you're like, I'll wait. And it becomes a habit of you're always postponing the urge. So what happens is your rhythm, the gut-brain axis, the communication between them becomes disrupted, and it's not as efficient as before. And people who tend to use laxatives, the problem is if you use it once, twice, that's fine. But if you use a laxative every time and it becomes habitual, what happens is that you're training your body you're training yourself to go and evacuate your bowels by using a mega stimulus, because the laxative, the tablet, when you swallow it, it's going to produce a mega stimulus, stimulating your sympathetic, parasympathetic nerves. And what happens now is when you stop using the medication, the normal physiological stimuli, which are the ones that, for example, when you get the distension of the wall, will not be enough to trigger you or to entice you to go to the toilet. So the laxatives, if you can, instead of using the laxatives, make sure you take plenty of water, so that there's so much water in the lumen that when it's absorbed, that your luminal contents in the rectum are not dry completely. That means it will be easier for you to be able to evacuate. So if you go to the loo and you produce pellets of feces like a goat, there's something that's wrong. You need to go and ask for help. Don't wait until they're rushing you. And we've had cases of people being taken to theater where they have to surgically remove it because it's so hard, like a stone, it won't come out. The role of fiber. Fiber is fiber in the food, dietary fiber, rather, that's the correct name. You have two different types. You've got soluble fiber and you've got insoluble fiber. Insoluble fiber is, for example, what is found in cabbages, in skumas. So what we chew, the cellulose that we cannot digest. Some of it might be digested by the colonic bacteria, and they might be able to break it down and release some more breakdown products, which can then be absorbed. But the more fiber that you have, the easier it is for even the colonic smooth muscle to grip. So it's not like a toothpaste trying to squeeze whatever's inside, it will grip and will be able to push because the substance, the content will have substance. That's the fiber. The other role that fiber has is that because it's acting like a sponge or like a Scotch-Brite or like a steel wool within the content, it will actually hang on to some of the luminal contents. So if you eat a very fatty meal, the fiber will absorb some of that fat, preventing it from getting to the walls and slowing down the amount of fat that is going to be absorbed from the luminal content. So it plays very many roles. When it comes to insoluble fiber, that's what you find, for example, in fruits, the mucinous, mucilage-like. I don't want you to say mucus because people think mucus is disgusting. But pectin, things that are found in murenda and in okra, okay, or ladies' fingers. That is the soluble fiber. And what it does is it prevents drying out or hardening of the luminal contents, and it facilitates the slippage of the passage of luminal contents through the gut. So that's why it's good to improve. Okay, another thing, of course, is exercise. When you exercise, even something as simple as walking 3 kilometers, 4 kilometers a day, you are actually going to be massaging your abdominal content, your abdominal organs, because you'll have a tightening of the anterior abdominal wall. And as it tightens, it compresses the underlying abdominal organs, so that you will also have like a massaging effect from the outside, which will help in propelling the substances. So you find that even if you haven't done exercise for a while, and then you start day 1, day 2, and you become quite regular, you'll notice that actually you're able to pass feces much more comfortably and easily compared with when you're just a couch potato or just sitting or saying you're reading all the time, studying in medicine. You need to exercise, not just for the brain and for the actual exoskeleton, but also for the benefit of the digestive system. Now, the picture that I showed you with the constriction when we started this afternoon showed you distended intestines. Okay, the colon was distended. We talked about the fat on top. This is probably from a person, I don't know whether that was human or not, that is taking a highly calorific diet, not exercising enough. So whatever they take in, remember we said that whatever you ingest will be processed along the gut. It doesn't matter whether you're full, whether you're obese, so long as you keep loading your digestive system, it is going to process whatever the luminal content there is. So what happens now when you have this distended distended colon or even small intestine? Remember we said that for absorption to take place, and even the final digestion, you actually need the contents to come into contact with the enterocytes or even the colonocytes. So when you have an overfilled, and I'm using that word, overfilled intestine, most of the luminal contents will travel through, and only the peripheral of it is going to come into contact with the walls, which means all the rest is not interacting with the walls of the gut. And you'll just get, because the body is warm, and there's lots of microorganisms, you're going to get putrefaction of the luminal contents. And if you don't evacuate your bowels as often as you should, you'll end up reabsorbing those products of putrefaction. Okay, and then the other thing is that you get atony of the smooth muscle. The smooth muscle is not able to knead and mix and digest because of this intestine is fully mixed, is always fully distended. So when you fast and you're able to empty the content so that the lumen is left relatively or even almost empty, then it helps in strengthening even the muscles, so that when they contract, they're able to contract completely and relax, and the activity within the gut is improved. Even the function of the gut is improved. Okay, I talked about the abdominal fat and how we said it's difficult to get rid of, because when you exercise, you're exercising the skeletal muscle, and any fat that is in the skeletal muscle, the build that goes. But even when you do sit-ups, you're exercising the rest of the body, but you're not exercising any of the muscle in the abdominal organs, because that is smooth muscle. So that's what the one I was saying, that if you want to get rid of that kind of fat, then you just need to stop eating for 3, 4, 5 days. The only thing is that eating is it's a habit. There are people who are even scared of being hungry, and they can't imagine even going 6 hours or even 12 hours without eating. But if you went for 12 hours without eating, or even 24 hours without eating, you wouldn't die. Yeah, I know you guys are a lot younger than me. Yes, you will feel hungry, but what will happen is that your body, when it realizes there's nothing else in the digestive system, it will now go to the stores and start using what has been stored up. So we do use the waist-hip ratio as one of the measures of obesity. There's also the skin thickness, where they pinch the skin either on the forearm or in the abdomen, and then they measure the thickness to tell you, because the fatter you are, then the greater the roll of tissue that is underneath. So we do use that as a measure of waist-hip ratio. And of course, we also compare it with the BMI and comparing your height and the rest of your build. So those are things that we do. I remember talking briefly about the rectum, and we said that you can give suppositories, administration of drugs per rectum. We said mostly these are drugs which maybe the formulation of the drug cannot be taken orally, or it can be deactivated either by the saliva or by the gastric acid, or it is unpalatable, it's not tasty, or the patient themselves could be comatose, and so you can't, force them to swallow. So what you do is you administer per rectum, and we said that the mucus in the rectum and the drug will be readily absorbed as it dissolves, and it will be circulated in the body, and you can achieve what you want with the patient. We also use the rectum, the mucosa there, to measure temperature. And the rectal temperature, okay, I know we do that a lot, especially with babies, but the rectal temperature actually gives you a temperature that is a better estimate of the core temperature of the body. Whereas when you put it in the mouth, okay, other than somebody that might break the thermometer, if you give it to someone who has just finished eating an ice cream, or has just drank a hot cup of coffee or a hot cup of tea, then the temperature is not really going to be an exact, it will not be the exact temperature of the body, of the core of the body. So sometimes that's why we use the rectal temperature. And yes, I think that is it. Okay, now I said I was going to share, I'm going to share these with you maybe probably by this evening or by latest tomorrow. But I think if you click on this link, I never wrote what it was, but I think it shows you something to do with how you can assist evacuation of feces. So that's one that I left there. But so if you get this link and just put it on Google, you should be able to get access to it. So thank you, and that is the end of motility. So we've talked about the gastrointestinal tract, we've talked about its functions, we've talked about blood supply, innervation, regulation, control, gut peptides. We even mentioned the blood flow and how it's related to this. And so now, so that we can finish this particular session, at least for this side, 2022, we're now going to look at secretions, because you cannot digest without knowing what the secretions are all about. Okay, so let's go through this and we look at secretions, and then if you have any questions, any comments, we can discuss them afterwards. Okay, so secretions of the digestive system. Okay, now secretions in the gut are directed from four sources. You have the goblet cells, which are single-celled mucus glands. Okay, they're found in the mucous membrane, interepithelial, and they're single cells found along the whole length of the gut. Occasionally, you also get organized glands. You can get secretory cells, which are located, for example, in the intestinal pits. Remember the crypts of Lieberkuhn? So that even as the intestinal secretions are being secreted, they will be secreted together with mucus. Okay, so we'll talk about the contents of each secretion. So you have goblet cells, you've got secretory cells found in pits, for example, the intestinal pits. You also have tubular glands, which are found in the wall of the stomach and the upper duodenum, which also release their secretions directly into the lumen. And then you have complex glands, also known as accessory glands of the gut. These are, for example, the salivary glands, the pancreas, and the liver. And the difference between the complex glands and the other ones we discussed earlier, the other three, is that complex glands have a duct. So they're situated away from the actual gastrointestinal tract, and they're connected to the tract via a duct, so that their secretions have to go through the duct to get into, to mix with the food. So for example, the major salivary glands, the parotid gland, submandibular gland, and also maybe the sublingual. Then you have the pancreatic duct, and you also have the liver, which empties its secretions into the gallbladder, and then the bile duct is the one which is going to convey the bile into the digestive system. So those are the sources. Secretions, or rather stimulation for the secretion, we normally have like three. So the major ones is, so you have contact of food with the epithelium. So the minute that either you've put food in your mouth or you have swallowed and the luminal contents have gone into the stomach or into the duodenum, as soon as that contact comes, that luminal content comes into contact with the epithelium, the tactile stimulation, chemical stimulation, distension of the wall are what are going to trigger secretion from that particular region of the gut. So you have receptors in the mucous membrane, not only for touch, you also have receptors for distension. So when the wall is distended, it means that there's a lot more content which has come in. And also you have sampling of the luminal content. So you have receptors which will tell you, give you information on the pH, on the osmolarity, the temperature even, okay? And all that information, that's what we're talking about, contact of the luminal content with the epithelium. Secondly, stimulation of the autonomic nerves. Now, basically, when you stimulate the parasympathetic nerves, you're going to get an increase in the rate of secretion, because parasympathetics normally act on the glandular cells. So when you stimulate the parasympathetic, you're going to get an increase in the rate of secretion. When you stimulate the sympathetic nerves, you get two responses. And I think I remember showing this in the very beginning when we started, and we had the diagram showing the communication between the enteric nerves, the sympathetic, parasympathetic, and the central nervous system. So you have some nerves that are going to directly contact the epithelial cells, the glandular cells. So by stimulating the sympathetic nerves, you can increase directly the activity of the glandular cells. Then you also have indirect results from stimulation of the sympathetic nerves. And this is where because when you stimulate the sympathetics, you're going to get vasoconstriction. When you reduce the blood flow to the gland, you're going to reduce the activity of that gland. So that's an indirect method. So that's why now you have the two. So stimulation of the autonomic nerves. The third way is where you have the involvement of the gut peptides. So you have the so-called humoral control. And this, as we said, was those peptides are going to be released in response to the presence of luminal content, the type or the consistency and the content of the type. So it depends on the meal, whether it is carbohydrate rich, whether it is protein rich, or whether it is fat rich. That will determine what is going to be found. And those are going to add. So imagine for the whole of the control, you have a mixture of everything. You've got contact of food with the epithelium, you've got your autonomic nervous information coming in, and also the gut peptides. So all of those have got to be very well regulated so that you have efficient efficient activity of the gut itself. Now, I also have here a couple of slides, I think there are 4 of them, showing you the mechanism of secretion. So basically, this is basic cell physiology, which we have summarized for you so that you can appreciate what is happening at the cellular level. Okay, so the nutrient material diffuses, or it is actively transported into the blood, in the blood to the base of the glandular cell. Okay, so these nutrients are going to come to the glandular cell and via blood, and they're going to come to the base of the glandular cell. The mitochondria then use oxidative energy to form ATP. And in the endoplasmic reticulum and the Golgi complex, the secretory substances are synthesized from energy from ATP and the substrates provided by the nutrients. Okay. The secretory materials, once they are formed, they're then transported through tubules within the endoplasmic reticulum to vesicles in the Golgi complex. Now, all of this, starting from the blood coming in, I'm coming in with the nutrients, to the synthesis of the organic material, to its being transported to the vesicles in the Golgi complex, takes about 20 minutes. So it is not automatic. It's not like switching on a tap or switching on a light. So what we're saying is that you need time. And perhaps this is also the reason why physiologically it is good for you to be able to chew your food thoroughly and very well, so that by the time that the food gets to the stomach will already have started secreting the secretion with the necessary enzymes in it. So then after that, the materials are added after in the Golgi vesicles, or at least at that point, and they're modified, they're added to, they're concentrated, and eventually discharged into the cytoplasm in secretory vesicles. The secretory vesicles are then released from the apical ends of the cell in response to either neuro or humoral stimuli via the process that you know of called exocytosis. Okay, so in exocytosis, basically what happens, you have a stimulus that causes the cell membrane to become more permeable to calcium. Calcium enters the cell. The calcium then causes the vesicles to fuse with the apical cell membrane. The cell membrane then breaks open, and the contents of the vesicle are emptied outside of the cell. Okay, so that is in summary. In addition, you must remember that whether it's enzymes or any of the organic material is never secreted by itself. It will always be secreted together with water and electrolytes. And what happens with water and electrolytes is that you get the neurostimulation causing active transport of the chloride cells into the secretory cell. This will cause a buildup of excessive negative charge, which will then cause positive ions to come in to try and balance this charge. So the sodium ions are going to move into the cell following the active transport of chloride ions. Now, when you have an excess of both the positive and negative charges, this is going to create an osmotic force that is also going to drive water into the cell. Excuse me. So that's how the water and the electrolytes are going to travel together into the cell. Then the pressure of the cell, or the pressure inside the cell, builds up, and it will continue building up until it causes minute openings in the secretory border of the secretory cell. The cell volume and the hydrostatic pressure continue to increase. The cell will enlarge as it swells, and eventually the water, electrolytes, and the organic materials will be flushed out of the secretory end of the glandular cell. So what I've done in those four is to basically summarize secretion, and I would advise you to go and look up your basic cell physiology, which you did in last year. Even if you passed your year, it's okay, so that you can understand this process better. So how much fluid will end up in the lumen of the gut? Okay, people have measured this, I guess, a long time ago, and they talk about two types of secretions: endogenous and exogenous. Now, endogenous are those secretions that are going to come, for example, from the saliva or in the mouth, from the glands lining the esophagus, the stomach, the small intestine. All that is what we're calling endogenous secretions. That totals to about 7 liters in a day. So exogenous secretions are those secretions that you ingest, the water that you drink, the sodas, the tea, the porridge, the food that you eat, if it has soup, if it doesn't have soup, okay? So, and what they're saying is that the exogenous secretions only total about 1.5 liters, compared with the 7 liters that are going to be pouring in from the secretions. So, from the endogenous secretions. So you can see that in a day, you're going to end up with 7 plus 1, okay, approximately 8, almost, let's say between 8 and 9 liters along the gut. However, fortunately for us, most of that is going to be absorbed during absorption, when you're absorbing the byproducts of digestion. And in the colon, whatever water remained will also be absorbed, because remember we said the colon absorbs water against the concentration gradient of water. So that what happens is that when you pass feces, it will only contain about 200 mLs of water. So basically what we're saying is that your digestive system recycles the fluid in the body. So if you have hypovolemia, if you're dehydrated, that means the secretions are also going to be diminished, because the body doesn't want to rock the homeostatic balance in the body. So you find that if you're dehydrated and then you give somebody or someone who's dehydrated, you give them a rich, nutritious meal, they'll have problems, difficulties in digesting it. Whereas if you give them a thin, for example, if it's soup, let it not be thick in consistency, let it be watery, because that water, most of that water is going to be absorbed as water. So when we talk about water and water requirements in the body, it's not just what you drink. And if you're dehydrated or if you have a water depletion and you give someone water and tell them to drink, homeostasis you'll reach a certain level. After that, if you force yourself, you'll vomit, because your body is going to recognize like there's a flood of water into the body and it's going to rock the homeostasis balance in the body. So that is what is important. And if you're ever hot and dry and dusty, or you've been very, very thirsty, you see, usually what we do is we listen to the adverts and you reach out for a soda. No, that soda has got so much sugar in it, and it's got so much coloring that your body is going to have to use water to digest or to remove the sugar, and also to deal with the coloring and other sweeteners that are being used these days. So it's important for you to know how much water goes into the body and how much is recycled. So you can also see with this amount that if someone has severe diarrhea or severe vomiting or continuous vomiting, you can end up losing a lot of fluid. They can be volume depleted. Now, this is also direct from the textbooks. And I guess the figures, it depends on who was studying and what they were, but this just gives you a rough idea. So the figures may not all tally up with from slide to slide. But what is also important with this is that it gives you not only the amount, the volume of secretions from the particular part of the gut, it also gives you the pH. And as you can see, saliva is neutral, just tending towards acidity, but very, very slight. And that's why saliva is able to neutralize acidic food that you eat. Saliva totals about 1 liter per day on average, but your gastric fluid is slightly more. It's about 1,500 if you were to measure within 24 hours how much of the fluid is secreted. But you can see the pH difference. Gastric fluid, because of the presence of hydrochloric acid, you have a pH of between 1 and 3.5. So it is highly acidic. And also the stomach mucosa is arranged in such a way that it can withstand this acidity without damage. And that is why when you release gastric content, you find that most of the rest of the secretions are going to be alkaline, because one of the things they first have to do is to neutralize the acidity of the chyme, so that then now the processes of digestion can continue. So pancreatic juice, about 1 liter, okay? The pancreas is about the same size as, almost the same size as a parotid gland. So, and they're very similar in architecture and even the way they function. The only thing is that the pancreas or pancreatic juice is much more alkaline than saliva. Bile is also alkaline, about 7.8, also about 1 liter in a day, depending on what you've eaten. Then the small intestine, because remember, this is the longest part of the gut. The secretions from the intestinal glands totals about 1,800. And you can also see how alkaline it is. Then when you come to the Brenner's glands, which are found towards the end of the small intestine, the secretions are less. And the colon itself doesn't secrete much. Remember, we said that what happens here, most of it is going to be absorption of water, but you do get secretion, mostly because you're going to get excretion of substances, and they're going to have to move into the lumen. And in order for them to be excreted, they'll have to move with water. And also, you also have a mucus, because it's going to protect the mucous membrane of the colon from being irritated in whichever way by the colonic contents. So that you can go and look at in your textbook. When it comes to regulation of secretion, okay, this slide, okay, talks about regulation of secretion, but I think you can extrapolate somehow to regulation of gastric tract, the digestive system, because you have 3 phases of regulation. And the 3 phases, this was the experiments that were done to come up with, to show these distinct phases, were experiments that where they were looking at the gut, at the stomach, the gastric mucosa, and looking at the pancreas. So they were actually measuring pancreatic and gastric juices. But to a certain extent, you can expand this to actually cover the function of the gut itself. So you have 3 phases: cephalic, gastric, and intestinal. And why they're named in those 3 phases is because that is where the stimulus is. Okay, so the stimulus, when during the cephalic phase, it's where you're going to get stimulation involving the cephalic region. Then you have gastric phase, where you have the stimulus is in the stomach. And then you have the intestinal phase. So the cephalic phase is where you're going to get stimulation from sight of food, the smell of food, sometimes even hearing. If you're sitting somewhere and you're hungry and you hear somebody in the next room, and you can hear the gas being put on, they're peeling or they're making noise, you can hear the onions frying in the sphria, even before you smell it. That sound will cause you to anticipate a meal, and that will also start to trigger off gastric, to trigger intestinal, gastric, and also salivary juices. So the thought even of food, especially if you're watching YouTube, if you're reading a book and they're describing a meal and you're quite peckish, then you can even start simulating. So what I want to tell you is that secretions will start long before even the food gets to that region of the gut. And of course, when you talk about memory, it's you remembering maybe a meal that reminds you of something pleasant that happened before, or even unpleasant. remembering your mother's or your grandmother's favorite meal that they like cooking for you, all that can cause cephalic stimulation. So, I mean, all of this is in the cephalic region, so it's going to start causing secretions. And the first secretions that are going to be created are the saliva secretions, and then also the gastric secretions. So what I'm trying to say is that during the cephalic phase, the gastric phase, and the intestinal phase, you have secretion occurring all along the gut. Secretion never comes to zero. You can get baseline, but it will never be zero. But during the cephalic stimulation, when the food is in the mouth or on the plate before it gets into the mouth, and when you start chewing it, before you swallow, before the food gets into the stomach, the maximum stimulation or secretion is going to be occurring in the mouth. When that food or the bolus arrives into the stomach, then you're going to get a kicking in of the gastric phase of secretion. So you're going to get a minimizing of the cephalic phase, especially if you've finished eating the meal. But in the stomach now is where you're going to get enhanced secretion because there's already luminal contents there. So the chime in the lumen, distension of the gut wall is going to trigger the secretion of gastric juices. Once that is done and you get gastric emptying and now the contents go into the intestine, that is what is going to trigger now maximum secretion in the intestines. But even now where you have maximum secretion, for example, in the intestines, it doesn't mean that the gastric secretions have been switched off or the saliva has been switched off. They're still secreting, but not as much. So what these phases do is they show you where the maximum secretion is taking place. And remember, the chief stimulant is the presence of that chime or the luminal content in that part of the gut. So now let's look at the secretions as we go along the gut and what they do, what they're made of, so that we can understand the function. Now, you have mucus secretions. Okay, now mucus is secreted along the entire length of the gut, starting from the mouth all the way to the anus. Saliva is actually a combination of both mucoid and serous salivas. And the mucus that is produced, as we said, comes from goblet cells or even from the glands like the ones we mentioned along the gut. The mucus has a protective role. What is it protecting against? It's protecting against acidity so that the epithelial cells are not damaged by the pH. It also protects by forming a layer or like lining the surface. It prevents the enzymes from getting into contact with the epithelial cells. Because remember, when you have protein digesting cells, they don't know that this is cow protein or this is chicken protein and this is human protein. They will digest whatever protein they come across. The mucus also acts as a barrier because it helps things to slide along the surface without causing lacerations or tearing. So unless you swallow something sharp or jagged, it will just slip along the mucosa and it will not damage the epithelial cells or the enterocytes, if you want to call them that, if we're in the small intestine, because of that layer of the mucus. The mucus also acts as a lubricant, so that even when you're swallowing, when you have formed the bolus, already the food has been wetted and it is moist, and then it is sticking together. That's what the mucus does. It helps the particles to stick together. But then you also get the entire bolus being covered by that thin layer of saliva, so that when it travels through the gut, it is actually slipping along without causing any excoriation or lacerations. So the mucus forms a part of the mucosal barrier, which is what separates the luminal contents from the actual gut wall. And when you have problems or a thinning or a deficiency in that mucosal barrier, then you get problems. And that's one of the things that we'll discuss when you're discussing ulceration or ulcers in the stomach. So the esophagus, the colon, and the rectum are areas of the gut where the primary secretion that's found there is mucus. In the esophagus, remember the bolus, there's no digestion. Okay, let me not say, when you say there's no digestion taking place, strictly speaking, that is not true. Because the saliva, which is mixed with the food in the bolus, the enzymes, the salivary amylase will continue working on the carbohydrates. But there is no enzymes that are going to be secreted from the esophagus to be mixed with this bolus. In fact, the esophagus doesn't even mix the bolus. All it does is propel the bolus. It's a conduit, helping the bolus to move from the neck region through to the thoracic, region into the abdomen. Okay, the issue of heartburn, I shall not go through again. We discussed that yesterday. And we said that heartburn is a referred pain when you have the acid irritating the esophageal mucosa. So let's start now with the actual secretions that are involved in digestion, because mucus is not involved in digestion. It plays a greater role in motility and facilitating gastric function. So as we said, you've got two types of saliva, serous and mucus saliva. The parotid gland secretes purely serous. The submandibular and sublingual glands produce a mixed mucus and serous saliva. And in total, we have about 1 to 1.5 liters secreted per day. It is not secreted at the same rate throughout the day because saliva secretion is influenced by the circadian rhythm. And in fact, majority of the saliva is going to be secreted during eating, during mastication. Then you have higher rates of secretion when you're awake, and when you go to sleep, it diminishes. Sometimes can even come almost to zero, which is probably a good thing, because can you imagine waking up in the night to swallow? Yeah, you'd not have a restful sleep. And having said that, it probably tells you, that's why when you wake up in the morning, you have so-called morning breath, because not only have you reduced, or has the body reduced the saliva secretions, you've also reduced the number of swallows, the deglutition. Most of the swallows are going to be made during the day when you're eating, when you're talking, not at night. So it might be a good thing, is it, to brush your teeth before you go to sleep at night to try and reduce the morning breath, or to make sure that when you wake up in the morning, at least you rinse your mouth first before you partake of a meal. Okay. Now, the role of saliva in mastication is what we had said earlier. And what we said is that the more you chew, the more saliva you produce, especially saliva from the parotid gland. And that is what is going to facilitate digestion, which is why it's important for you to be able to chew your food well. The primary, how is saliva formed? There are two stages. The acinar cells, the glandular cells, secrete a fluid that is known as the primary fluid. And it is usually isotonic with blood. Now, once it is produced, it then is going to be directed, or it's going to be carried away from the gland itself, from the glandular portion, the secretory portion, and it will go along the ducts to the point of where it's going to be released into the lumen of the gut. So as it travels along the duct system, it undergoes modification. And as it is modified, by the time the saliva is being released into the mouth, it is actually hypotonic. So what do we call modification, or what happens along the duct? You get within the luminal content, the saliva in the lumen, you'll get an increase in potassium ions, you'll get an increase in bicarbonate ions, which means the potassium and the bicarbonate are going to be secreted into the duct. And in exchange for those, you're going to get the sodium and chloride ions being absorbed and being taken out from the saliva, or from the primary fluid back into the body, into the bloodstream, and being circulated, so that you have a change in the tonicity of the saliva. So you have primary fluid, which is isotonic with blood, and then it is modified and it becomes hypotonic. Saliva contains enzymes. We talked about salivary amylase and lingual lipase. And we said that lingual lipase plays a key role in taste. It enhances taste and the feel, the mouth feel. For example, like sweets. I'm just thinking the glass sweets, the KSL, that's water and sugar and a little oil, so that when you put the sweet in the mouth, it rolls around, it feels nice. It doesn't stick in one place. And we also said that when you're steaming food, you normally put a little bit of oil to make it, okay, it will look a little bit shinier. And also when you put it in the mouth, it feels, it may not taste any different, but it will feel better. So the mouth feel is very important. Salivary amylase, as we said, it initiates carbohydrate digestion. But I'm sure we've agreed, most of you have asked you how many times do you chew before you swallow? Yeah, some will say once, twice. Okay, I guess it depends on whether it's rice, whether it's ugali, or whether it's meat, okay, or something fibrous like sukuma wiki or kunde. But what I'm saying is that the food doesn't stay in the mouth long enough for the salivary amylase to digest or to start digesting the carbohydrate. Fortunately for us, only about a third of the digestion of carbohydrate occurs in the mouth. The bulk of digestion occurs in the small intestine as a result of action of the pancreatic amylase. So that is why you find that even if you don't chew your food, that carbohydrates will still be digested because the pancreas will do a fantastic job with that. Now, one thing that you need to note, because this is different when we go down lower in the gut, is that salivary amylase is produced in its active form. Many of the pancreatic enzymes are produced in an inactive form, and then they have to be activated so that they can start acting. So they're not active in the gland, they're active when they get to the lumen. And also enzymes can be inactivated by acidity. So that's why you need to neutralize the gastric acid. Others, you'll have enzymes that are going to be inactive and not be able to do their job. So what goes wrong if you don't have enough saliva? If your mouth is relatively dry, or you find that you can't talk, your mucous membrane sticks together, or your lips, or the inner surface of your lips or your cheeks stick to your tongue, or your tongue stick to the teeth, or your tongue sticks to the roof of your mouth, that is considered dry mouth, and that is what is known as xerostomia. Now, people who complain of dry mouth find it difficult to talk, find it difficult to swallow, and they may even feel like a burning sensation in the mouth because you tend to get an inflammation because the mucous membrane is supposed to be moist, and when you dry it, then you're going to get inflammation. So xerostomia is not necessarily zero saliva, it's just relatively dry. And like I told you, normally, physiologically, we normally produce saliva all the time. But when we are anxious or stressed, then your sympathetic nervous system kicks in, you get vasoconstriction, and your saliva production is diminished. And so you feel some elements of dry mouth. People who don't have enough saliva or enough of the serous saliva are not able to clean their mouths properly. You know, after you finished your meal and the saliva is still coming out, your tongue can remove particles from in between the teeth. You will swallow so that you empty your mouth, so that what is left is just saliva. So the saliva also helps to cleanse the oral cavity. And if you don't have enough of that, or the saliva is too thick to be able to do that cleansing function, then it's very easy for you to develop dental caries because the food remnants will be broken down by the oral microflora, and the acid produced is going to destroy the tooth tissue. If we move on to the stomach, gastric juice or gastric secretion contains water and salts. It also contains hydrochloric acid, pepsins, and intrinsic factor, okay? And obviously mucus, which we started with. So water will be there and mucus. Now, the purpose of gastric fluid is to initiate the digestion of protein. So chemical digestion of protein is started in the mouth. Sorry, it started in the stomach. But strictly speaking, digestion of all foods starts in the mouth because mechanical digestion occurs in the mouth. So when we ask you about digestion, you have to be clear whether you're talking about mechanical digestion or chemical digestion. Because most people, when you ask them, where does protein digestion start? They always say in the stomach. And then you wonder, how did the protein get to the stomach? You must have chewed it. So mechanical digestion occurs in the mouth, but chemical digestion starts in the stomach. And hydrochloric acid is critical. Whenever we ask students what is the purpose of hydrochloric acid, they always say to disinfect the food. Okay, fine, you can kill microbes, yes. But I think the prime or the most important factor of hydrochloric acid is to unfold the protein molecule, break some of the bonds so that you can stretch out the protein molecule so that the enzymes will be able to get to the active sites to be able to cleave the protein into smaller pieces. And if you don't have hydrochloric acid, protein digestion will not be started. It will be difficult to digest protein. Where does the gastric fluid comes from? It's released from the gastric glands. And there are 3 types of cells. You have the parietal cells or the oxyntic cells. You've got the chief or peptic cells. And then you also have the pyloric gland cells. Now, the cells in the pylorus, in the glands there, they secrete mostly mucus and gastrin. Okay, so the mucosa of the pylorus will secrete a lot of mucin. The mucus will help to propel so that this acidic content is now able to flow freely into the duodenum. And then you also have gastrin. But remember, gastrin does not mix with the food. Gastrin remains in the wall and travels in the blood to the different parts of the stomach wall. So then you have pepsinogen, which is produced in its inactive form. But then when it gets into the stomach, it will be activated. Then you also have hydrochloric acid, which is secreted by the parietal cells, and intrinsic factor. Now, the secretory canaliculi branch throughout the parietal cells. Okay, so the next slide, I think I'm going to tell you about how the cells are able to produce hydrochloric acid without damage to themselves, because as they produce, as you get more more protons and more chloride ions, you're going to get an increase in the acidity. How is it that these cells are able to secrete hydrochloric acid without damaging their own organelles? And that's what we'll show you in the next one. Okay, so you have hydrochloric acid transporters and chloride channels, which are located in the lining membrane. And you also have canaliculi, which form within the parietal cell. But a note about intrinsic factor is that intrinsic factor is secreted in the stomach. It binds with vitamin B12 in the ileum. And then this complex, the complex of intrinsic factor combined with the B12 will then be absorbed in the colon. So if you don't secrete intrinsic factor, maybe there's damage to your gastric mucosa or you're not secreting enough. Even if you're eating food with plenty of B12, it will not be absorbed because it needs to complex with the intrinsic factor, and then it is absorbed, and the absorption takes place in the colon. Okay, so I'll use this diagram to explain, summarize, and then I think we got a couple of cells with texts explaining what exactly happens in an active parietal cell. Now, as you can see, this cell, which is different in color, it's yellow. This is the active parietal cell, and it is specialized to produce hydrochloric acid secretion. And the secretions are going to end up at the right end beyond the arrow. That is the lumen of the stomach. And you can see these cells are in the mucosa of the stomach, so they're lining, so the flow of acid is going to be towards the right. So the blood vessels are going to be on the base, on this side, on the left-hand side, bringing in the nutrients. And what happens is the cytoplasm will rearrange itself so that the nucleus will be found closer to the base. And then you have canaliculi, which are going to form and fuse and coalesce, creating a so-called space in the cell. Okay, so the canaliculi, instead of them being separate, they join up and they form a potential space within the cytoplasm. And in this potential space is where the chloride ions and the hydrogen ions and the water are going to be directed, so that as more and more hydrochloric acid is formed, it will be concentrated and will be lying in the canaliculi, not in the cytoplasm of the cell. And then what happens is that when the cell secretes, the hydrochloric acid will be pushed out of the apical aspect of the cell, and it will be directed into the lumen, where the hydrochloric acid will mix with the gastric juice is going to mix with the luminal content. So these couple of slides explain that. And what it explains is that the chloride ions are actively transported first into the lumen of the canalicula, into that potential space we're talking about within the cell. So within the lining of the canaliculi, you have pumps, and the sodium ions, the chloride ions will be actively transported from the cytoplasm into that space, followed by sodium ions. Okay, no, sorry, okay. You have chloride ions going out of the cytoplasm, but the sodium ions will be actively transported into the cytoplasm. So that the net result is a negative potential inside the canaliculi. And then eventually what is going to happen is you're going to have more sodium more potassium than sodium ions moving from the cell cytoplasm into the canaliculi. So what you're going to get is the formation of potassium chloride and small amounts of sodium chloride, which is going to enter the canalicular space that we talked about. At the same time, you're going to get water dissociating into hydrogen and hydroxyl ions inside the cytoplasm of the parietal cell. The hydrogen ions are then actively secreted into the canaliculus, so they're going to follow the chloride ions. And the hydrogen ions are going to be exchanged for potassium using the hydrogen-potassium ATPase. The sodium ions will then be actively reabsorbed by a separate sodium pump, so that what you're going to have is that most of the sodium and the potassium will have diffused into the canaliculi and then be reabsorbed into the cytoplasm, while the hydrogen takes their place. So what you're saying, the positive ions, the potassium and the sodium will move out, and then they'll be taken back into the cytoplasm. But the hydrogen ions, once they cross over and they go into the canalicular space, they will not be reabsorbed. So what will happen over time is you're going to get a strong hydrochloric solution in that potential canalicular space. The hydrochloric acid is then secreted into the gastric lumen, and it will pass out of the cell without damage to the cell or the cytoplasm or the organelles of that particular cell. Now, the water passes into the canaliculus by osmosis as a result of the extra ions that are in the canaliculus. So that the final secretion, what you find in the canaliculus before it is ejected into the stomach, is going to be a combination of water, hydrochloric acid, potassium chloride, and small amounts of salt, sodium chloride. And the hydrochloric acid is the one which is going to be most concentrated. So you can see it's a mixture of electrolytes, but basically what you're going to end up with is mostly hydrochloric acid. Now, the carbon dioxide that is formed in the blood, or the one that is formed during cell metabolism by the parietal cells, combines with the hydroxyl ions, because remember the hydrogen ions are the ones which are going to go to form hydrochloric acid. The hydroxyl ions will then react with the carbon dioxide to form bicarbonate ions under the influence of carbonic anhydrase. The bicarbonate ions then diffuse out of the cytoplasm, and they're moving out in exchange for chloride ions. so that they go, the bicarbonate ions will go into the extracellular fluid, and then later they'll end up in the blood. So the chloride ions will move from the extracellular fluid through the cell, the parietal cell, into the canaliculus. So that you have the bicarbonate ions and the chloride ions traveling in different directions. So you can see that as the bicarbonate ions move out of the cytoplasm into the connective tissue, into the blood, you're going to get an increase in alkalinity of the blood. And this usually happens after you've ingested a meal, during digestion of the meal. And this is known as the alkaline tide, because you have this flow of bicarbonate ions during digestion after you've ingested a meal that flow into the blood, causing an alkalinity in the blood during this process of digestion. And once digestion finishes, then the blood comes back to normal. So this is what is known as the alkaline tide, and you can read about that in the exam, in the book. So this diagram summarizes gastric acid secretion. You can see the stimulants here, gastrin, acetylcholine, histamine, okay? And the acetylcholine and gastrin are the ones responsible for the production of calcium ions, and the calcium ions then act on the protein kinase, but the histamine works via the cyclic AMP. And in that way, now you can see now here the exchange of the potassium and the hydrogen ions. And so if you have a look at this diagram, it also explains nicely the alkaline tide, because you can see, so we've combined everything in this diagram. It summarizes all that happens during the formation of hydrochloric acid. So when it comes to medical interventions, especially with people who have a lot of acidity, the main aim is to reduce gastric acid levels in the stomach so that they don't permeate through the mucous membrane or through the mucous barrier and damage the epithelial cells. So usually what people used to give were antacids, which probably would work temporarily, and then you get a rebound, because you can't coat the stomach and the coating remains. So long as the stomach is mixing and interacting with food, it gives you temporary relief. Then there's a time they used to do selective vagotomy, because remember we said that majority of the nerves in the vagus nerve are sensory, carrying information from the vagus to the central nervous system. But however, in the vagus nerve, the nerves are not labeled. So if you were to go and cut some of the fibers, you wouldn't be too sure which ones you're cutting, whether they're the ones that are responsible for secretion or whether they're responsible for motility or for controlling motility. So usually when they did vagotomies, they discovered that people had a lot more side effects because you weren't too sure how much or how many of the fibers you need to cut. But these days now, we've got things that are more selective, and they're agents that are known as proton pump inhibitors. So proton pump inhibitors are the ones that we're using now. They don't cause side effects, like they're not temporary in nature like the antacids. They're not cause other side effects, like for example, the selective vagotomy. I'm not saying that they don't have their own problems. They do. Some people react, or some people get greater side effects than others, but they do a better job in reducing the acidity than these other two procedures that were used before. And remember, we said that histamine, because there's always basal production of hydrochloric acid, even if you were to do a vagotomy, even if you were to control and remove the others, the acetylcholine, because histamine is always being secreted, and you cannot block the release of histamine. And histamine stimulates hydrochloric acid. So even after doing all of these, there's always a basal minimum of hydrochloric acid. And I think they've also agreed that it's not the hydrochloric acid that causes the ulceration, it is a breach in the mucous membrane. Maybe you're not producing enough mucus, or there's a thinning or atrophy of the mucosa. So that can be what can be causing problems there. Another diagram here to show you what happens in the fundus and in the antrum. And it shows you now the mucosal cells, the parietal cells, and also when it comes to the antrum, the G cells and the D cells. Yeah, the D cell is the one responsible for secretion of somatostatin, okay, which also influences hydrochloric acid secretion. So this is a summary, and I'll leave you to be able to have a look at that in closer detail. So let's move on to the pancreas. The pancreas produces, we said, secretions, and we have two components of these secretions. You have an aqueous component, a watery component. This is one which is rich in bicarbonate. And then you have the enzyme-rich component, which contains the enzymes that are responsible for digestion of fat, carbohydrate, and protein. Now, the main enzymes are for protein is trypsin, chymotrypsin, carboxypolypeptidase. The main enzymes for carbohydrate digestion are the pancreatic amylase. And we told you that even though you have amylase being produced in the stomach, even if you didn't make use of it, or the salivary amylase didn't work at all, the pancreatic amylase would be able to deal with the carbohydrate digestion quite adequately. Then you have fat, the main enzymes for digestion of fat, which are the pancreatic lipase, cholesterol esterase, and also phospholipase. Now, the protease enzymes are secreted in their inactive form. They are produced in the form of zymogens, and this is a way in which the pancreas itself is protected from being digested from the enzymes that it's producing. Now, the zymogen, or when they are released into the duodenum, into the lumen, they are then activated by an enzyme called enterokinase. So the activation of the enzymes does not take place in the pancreas, it takes place in the lumen. While the pancreas is secreting the enzymes, it also secretes a trypsin inhibitor, which also helps in preventing digestion of the gland tissue. So you can see, so one, the pancreas secretes enzymes in their inactive form. Secondly, it produces a trypsin inhibitor, which will prevent the trypsin from being activated and digesting the gland. Then you have the bicarbonate ions, the watery component, the bicarbonate ions and the water. These ones are not secreted by the pancreatic glandular cells. They're secreted by the epithelial cells that line the duct and the ductules that lead from the pancreas into the duodenum. So that will be the source of your bicarbonate ions and water, and you can see the source of the enzymes. Now, a note about bile. Bile, remember we said yesterday, is continuously secreted in the liver. It is produced in a dilute form, and once it is stored in the gallbladder, apart from being stored, it also undergoes concentration as more and more water is absorbed by the gallbladder lining. Bile contains bile salts, cholesterol, lecithins, bile pigments, and also electrolytes such as sodium ions, chloride ions, potassium ions, and bicarbonate ions. The major role, or the most important role of bile, is the emulsification of fats. Now, emulsification is, for example, if you took a teaspoonful of oil and swallowed it, it would form lipid droplets. But the droplets would be so big that the enzymes would not be able to effectively digest that lipid droplet. So what happens is that you get emulsification. So the bile helps in breaking up those lipid droplets into tiny, tiny, tiny droplets. Okay, for example, if you put a teaspoonful of oil in a bottle of water that was half full, and then you shook it so that you can thoroughly mix, you'd end up with mixing oil with water, because the droplets would get tinier and tinier, and they'll be surrounded by water. They're not actually mixing. The oil and the water are still separate. But the formation of micelles, which is the second function, is that you get micelles which form like a conduit, so that the fat is going to be in the center, not surrounded by water. And the micelles are able to carry the fat from the lumen to the wall so that the fat can then be absorbed once it is being digested. And the droplets, as they get smaller and smaller, you increase the surface area for the lipid digestive enzymes to work. Bile salts, even after they perform their function, because they're going to be active along the whole of the ileum. Remember, they're going to be released into the duodenum or in the early part of the duodenum. They'll be mixed, the bile salts or the bile will be mixed with the luminal contents, and most of it will be absorbed along the ileum, so that by the time you get to the terminal ileum, majority of the bile salts will have been reabsorbed and taken by the hepatic portal vein back to the liver so that they can reform new fresh bile. So very small amounts are lost in the feces. And this is how the body is able to conserve majority of the bile so that it doesn't spend so much time making fresh bile every time that it is needed. So this pathway that the bile takes, being released from the gallbladder into the lumen of the gut, all the way to the terminal ileum, being absorbed, going into the hepatic portal vein, going back to the liver, the formation of fresh bile, going back to the gallbladder. That cycle is known as the enterohepatic circulation. And it's a way in which bile salts are conserved so that every time you need them, the body is not making them afresh. And they say that when you have a very fatty meal, bile acids can be recycled 2 or 3 times by the time that meal is digested. So if you don't have a lot of fat in your food, then the enterohepatic circulation is slower. You don't get as many cycles, maybe only once. But the more fat that you eat, the more fat in your food, then the more cycles of enterohepatic circulation that take place. And in that, because you're increasing the frequency in which the bile is circulating, sometimes what happens is that the bile, as it is being formed, it is not consistent and it can change consistency. And one of the problems that you'll face is the formation of gallstones. Intestinal secretions contain mostly electrolytes, water, and mucus. So remember, water and mucus are going to be produced along the entire gut. The mucus as a protective layer, the water to keep the membrane moist. The intestinal secretions mostly protect mucosa from mechanical damage, especially when the luminal contents are passing. But the secretion rate increases during and after a meal. Okay, during the meal or even after a meal when the meal is now being digested. Secretion from the intestine is stimulated by distension of the wall and mechanical stimulation of the mucosa. And the secretions are formed by the enterocytes in the crypts of Lieberkühn, and the secretions are mostly pure extracellular fluid. So the normal fate of this intestinal secretions is rapid absorption in the villi. Okay, so remember, because there's a lot of water content in the intestinal secretions, they're going to, when enzymes are being secreted or being produced, they're going to travel with water. When the electrolytes are being absorbed and even the substances are being absorbed, they cannot be absorbed in the absence of water. So majority of the secretions is going to be water. The 7, 8, 9 liters we talked about, most of it is water, and it ends up being reabsorbed as absorption of nutrients is taking place. The mechanism of production is usually the active secretion of chloride and bicarbonate, and followed by the movement of sodium and osmotic movement of water. Now, this is just a picture showing what happens when you have infection with cholera, the Vibrio cholera. This organism, when you're infected, it produces a toxin, the cholera toxin, which then acts on the intestinal lining and stimulates an increase in secretions. So what happens is that the cholera toxin increases secretion. So you're going to get a net outflow of water from the cells into the lumen. And that's why you end up with diarrhea, because there's not, the secretion is greater than the absorption. And you can see now, not only is the chloride being secreted, but it's going to be followed by the movement of water and sodium ions. So the danger with cholera is not so much that that you've been infected, is that you're going to be losing a lot of fluid. And what we said is, of that 9 liters of water in the digestive tract in a day, if you lose even half of that, you can end up with hypovolemia. And if you add vomiting onto that, that makes things worse. And it is not the cholera, the Vibrio cholera, that is responsible. It is the toxin itself that interacts with the enterocytes. Finally, we come to the colonic secretions, which we said there were about 200 mLs when all the others were a liter and a half, almost 2 liters. So the colonic secretions are smaller in volume and they're richer in mucus content. So they're thicker, contain less water. And their function, we said, was purely protective and to help lubricate the canal so that substances can pass through. So what you've got to remember from your anatomy is that the colon has crypts of Lieberkühn, but there are no villi. So the crypts of Lieberkühn are not only found in the small intestine, they're also found in the colon. And that brings me to an end of secretions. Thank you for listening to me. If there's any questions, you're free to ask. Otherwise, this is a lot of content. And what I'm going to do is that all the presentation I've done so far, I will share with the class rep who can share with you. And I wish you the best next week. And when we meet now in 2023, we're now going to talk about digestion and absorption. Any questions? Any comments? Yeah, I can see questions here. Is gut coming in the cat, in the mid-semester cat, so that you don't read it? Well, I don't know. Up to what section of GIT should we cover? I'm not sure. I don't want. Okay, at least know the functions of the gut. Yeah. Traditionally, what we would do is we normally would not ask questions of what you're taught just before the cut in physiology. Okay. So it would be majority up to, is it renal that you did before physiology? I mean, before gut? It was renal? Wow, okay. So I hope I've answered your question. Okay, so if we don't meet again, then have a good Christmas after having done your cut, and see you next year.
Thank you.
Okay.